Good afternoon, everyone. I'm Charan. I'm a product manager with Microsoft. First, so happy to be here with everyone. I think it's a great opportunity to be able to drive policies and talk of the base problems that we face right from our respective spheres to bring about one policy that's going to change the government and the people's lives. So kudos to all of us. So the theme of our table has been to be the digital backbone, implementing what best way can we implement the Ayushman Bharat digital mission and how can Telangana be integrated with that. So the table was me, Charan, as a PM on AI PM from Microsoft. Then we were joined by Professor Deva from IIIT Hyderabad, who's also who's a researcher on the AI space, and Mr. Lax Chapuri, who is a CEO of a startup again working on the healthcare and AI space. So the mandated single standard, right? The question here is, should there be a single standard with Telangana or should it allow multiple standards? We believe that the FIHR protocol that is there, that should be the primary standard that's going to integrate with ADBM, sorry, ABDM. And if there are other protocols that exist, maybe they can exist, but it's a mandate that it should be interoperable with the FIRE standard and it should talk to the ABDM. And then what we also kind of arrived on is that the without the incentive being provided to the healthcare providers, is not going to be the adoption of the metrics. So incentive turns out to be one of the key metrics that has to be given. Otherwise, come on, we also have doctors here. If I'm going to ask you to give 30 seconds of your time more to help with ABDM versus you seeing another patient, I'm pretty sure we all know what the answer is going to be. Right? So there should be some incentive that's going to be given to you so that the integration is there. And they can be across the economic, social, or the strategic front for India. That could be one of the incentives. And the three frictions that we see for integration with the ABDM is, one, the consent withdrawal gap, where the consent is taken, we can take it at once at the patient level and later withdrawn. And with while AI is having an amazing reputation, right, we also have the other side of AI's reputation. So with that definitely is going to become as a big friction point. However, what we do at least in Microsoft, is we have explicit consent labels. So while we know we don't add one more step asking them to say, okay, do you give a consent or not, we kind of take it as a blanket consent and make it in red, bold, and capital that your data, you are consenting to use your data for AI space. So that is one recommendation that we make. And the third theme that came out as a friction is the fear of change and onboarding. I think there's also something we all agree as human beings, that humans are not necessarily designed to accept and welcome change. There are small section of people who do that, but in general, that fear of change is always there. So that is another big barrier to the adoption. Right? So going with the strong with the National Digital and Innovation Agenda, we have this course that we are seeing where with Viksit Bharat, the score is 9 on 10, where supporting data is presented to us. Skip forward. And Sridhar, you want to talk about the other points?
Based on what we typically see with Niti Ayog's focus area right now, specific to ABDM, there is a mapping done for what was written as a recommendation. So there were keywords that we identified in your document, which were matching to what Niti Ayog is right now professing for. And we found like these 6 areas primarily. Like the focus is how India is going to be in 2047. So we are talking about that kind of DPI, public infrastructure to be built for healthcare, which is future ready. It's not like we're talking about right now where we stand at this point of time, which means like many things that we heard from table 2, we need to like take care of many of those here. Similarly, now by 2030, we are going to see there is no... Right. So SDG goals are actually getting over now by 2030. There's no focus on SDG going further ahead from here. So we need to anyways go back and prove that there has been a lot of work done already and we have achieved some part of it. So there is definitely mapping to what you're talking about. So while we make some recommendations and we send this out, This is our action item, and these would be very helpful for us to focus on and map these and go back and make a section on where we stand on SDG. These recommendations would be a good gap fillers for even achieving those SDG goals. Similarly, on technology, we are talking about deduplication, which was one of the recommendations that we had from table 2. So we are seeing some of those areas, and we have just created all of this basis what you wrote on those sheets. We would be doing that. So we couldn't finish it on time. I mean, like while all of these were coming one after another. So if you would have like achieved all of it together, we would have given you a final consolidated presentation today itself. But we'll be sharing it. Like in another 2 days, we'll have a draft report. And then another 10 days, what's going to be presented at the ministerial level, we'll be sharing that also on the WhatsApp and email.
So to continue, a couple of questions more that we had is what should be the roadmap for Telangana's integration with the ABDM? The one consensus we arrived at as immediate goal for 2026 is to have a certification standard that has to be defined for say, okay, what should we have as certificate, so say M1, M2, M3 level certifications for the, for integrating with the fire standard and the ABDM. And in 2027, once we have the certifications and all our plan of action in place, Q2 of 27 is when we start with piloting this with the institutions, and the no-go criteria would be to see how good these are, because our institutions are with achieving the certifications, getting the consent pipeline ready, and the infrastructure set in place. And by end of 2027, we should be in a place where we now mandate the integration with the ABDM framework and mandate pushing out the data so that the integration completion begins by end of 2027. And 3 to 10 years, of course, once we are done with 2027, we scale and we adapt and we improve as we go forward. Now, one of the questions was on what happened and how did Morocco solve a similar problem. So to give a quick background on what happened, Morocco had a problem where they were siloed the EHR data platforms and they were not talking to each other. So obviously the fragmented data was creating a problem where there cannot be a standardization and a consolidation. So what Morocco did is come up with a single standard framework that is shared across the country, and they brought all the data onto that platform through pushing for adoption, allowing interoperability so that all the data is on one platform. And that they could achieve with standard, I don't remember the exact name of it. I have to look it up. It's a pretty mouthful of the standard that they've achieved. But they've had a single framework when the entire country was brought on board that platform, and data exchange became possible. So this is very similar to what the Ayushman Bharat Digital Mission is trying to achieve. And these lessons can directly be implemented where we now remove the fragmentation and start consolidating everything onto one platform. Right? So ownership, of course, Telangana government leads this with the IT department, with all the consolidation of it. And we, of course, have to work in tandem with the National Health Mission, the technology team, and the leadership team. Obviously, the Niti Aayog and Ministry of Health and Family Welfare has to be bought and framed so that this is all brought onto the national framework. And institutions like IIIT, of course, and I'm pretty sure at some point the organizations such as mine and all the partners that we have can play part in making sure that this mission is successful. So, of course, we have the compounding returns across this, and I can already see with the ABDM framework, it's not just the patient exchange, information exchange, there can also be the the complementary services that can get benefited with the data that is coming in, because data is gold. The moment you have data, the sky is the limit to see what you can do with it. So that can that. And so for now, I think the launch rationale is launch with a pilot program. I think there was one other question. I'm not sure if that is covered in one of the slides. The question was, the very obvious thing, how do we prevent a two-tier system where the hospitals, the large hospitals with the budgets and the man force and resources can do this versus the what was the term for it? I love that term. Dawakhana, Gali Dawakhana? Basti Dawakhana, right. I love that term, Basti Dawakhana, or the small clinics. See, before coming, I was doing a quick research on this, and high-level rough figures is that today, 60% of the Indian population still goes to small clinics, especially for non-interventional treatments, like your diabetes treatments or something that does not require a surgery. In fact, only about 10% of population or even less comes to large hospitals such as Yashoda or any other large hospital that is there. So solving problem for the small clinics should be the first priority. So that if you solve that problem, you are obviously solving it for the large hospital. So while the two-tier system is existing, the one way to come up and beat that system is to go a mobile-first solution where the data upload is easier, the barriers to entry are removed. So and the data sharing becomes easy where they can share it via mobile phone, because that is one certainty that we have thanks to our QR codes on the phone. Right? So smartphones are an almost given certainty. And I'm also basing this on my own personal experience traveling through India for when I work for an agri startup, where a village sitting almost 5 hours away from a city like Ranchi in Jharkhand. Right? There, people are able to do an annual agri-business of close to 80 to 90 lakhs turnover just using a mobile phone. So the adoption of mobile phone is no longer a barrier or no longer an inhibition. People are welcoming technology. So similar thing can be used here where you make it mobile first to share the data. And when that can be done easily, then we can get rid of the two-tier system. So classification, so start with a pilot program for it. So we can start off with a small city. You can take two extremes, one city like Hyderabad and one small tier 3 town or a small village to run this, run it through the pilot program. So we said 2027 Q2 and we start the adoption. That's when we can start piloting this and have the ownership clearly defined. And one other thing that becomes a big barrier over and beyond technology is the governance mechanism, right? So I think the next table is going to cover that. But the moment we have a strong ownership and governance mechanism and have an agreed upon national value that's easily communicated, then this mandate can work. So those are the points.
Thank you. I think we'll call the table 3 now. I'll quickly pull those presentations.